I'm just going to introduce our speakers who have taken the time out to be with us today. So first we have our INMO President, Karen McCann, as well as being the President of the Irish Nurses and Midwives Organisation. Karen is an advanced nurse practitioner in the Emergency Department of Dublin's Beaumont Hospital. She qualified in 2008 as a nurse and has worked in the emergency department since in various roles from staff nurse to CNM2. Whilst in these roles, she completed her postgraduate diploma in emergency nursing and masters in nursing in the Royal College of Surgeons. She also holds certificates in the prescribing of drug and ionizing radiation, as well as a certificate in advanced clinical skills from UCD. And we have with us as well Maurice Healy. Maurice is an advanced nurse practitioner specialising in intellectual disability in Ireland and has over 35 years experience as a nurse, lecturer and staff trainer. He trained as a registered nurse in intellectual disabilities in 1987, subsequently qualifying as a behavioural therapist. He continued his education by completing a diploma in training and development and a Bachelor of Science in Nursing. He then completed his Master of Science in Intellectual Disabilities at the University of Birmingham in 2012. He currently works for the Brothers of Charity Ireland, covering the Galway region. On a daily basis, Maurice utilises behavioural assessment to direct the use of practical strategies and supports grounded in the model of positive behavioural support to support individuals and their family. His special areas of interest is in autism and the impact of sensory processing and integration. And finally, we have Aisling Dixon. Aisling is a community midwife and winner of this year's Waterwipes Pure Foundation Fund. She is a passionate and incredible midwife and provides midwifery-led continuity of care to women. So thank you so much to each of you for joining us. So we have a couple of questions first, if that's okay. I'll throw it out to all of you, and whoever wants to answer first is welcome. What is your day-to-day work like?
Well, I can start if that's okay. I can start the ball rolling. I suppose my day-to-day job it's like everybody's. It's extremely busy. I am part of a team of 5 who work off the major screen in the emergency department. And we also have a team of 4 AMPs who see minor injuries, and our team of 5, we see an array of symptoms such as chest pain, VTE, abdominal pain, ENT issues, and so on. So we would start the first point of care with the patients when they come to the emergency department. We refer them on for diagnostics if that's what's required. We administer analgesia or antibiotics and refer them on accordingly, or they may be discharged home. So we would complete a full episode of care for that patient within our scope of practice. So again, it is a busy day. I mean, we cover 7 days. We don't do night duty, but we do the 7 days. It's extremely busy, and often, you know, your day is kind of underpinned by, you know, access to diagnostics. So sometimes you feel like your day is like you have the countdown clock ticking at the back of your head all the time, saying, right, I better hurry up, I need to get an ultrasound done, or whatever the case may be. So it is a very fast-paced day, but a very enjoyable one, because you see a throughput of patients, and you know, and you complete their episode of care, whatever it may be, that they may be admitted or they can be discharged home. So again, it's a great job, and I absolutely thoroughly enjoy it. And the pace that they work at, we're very much used to it, and that's how we roll, really.
That's great, Karen. Thank you so much.
Do you want me to continue?
Yeah, go ahead. I'm going to be a gentleman.
Perfect. Hi there, I'm Aisling. I'm a self-employed community midwife. I also work in the hospital setting. I'm a candidate AMP at the moment. So with regard to my day, I suppose in the community, so I do this by part-time, but I suppose speaking for all of our midwives, no, you couldn't plan any day really, such as the nature of labour and birth. So we, in the Community Midwives Association, except for our blocks of time off that we would pre-allocate and manage our caseload around, individually offer a 24 hours a day, 7 days a week service. And we look after women from probably around the 20-week mark through to 2 weeks postnatal, and providing them antenatal care, and then labour and birth. So the antenatal part, we can obviously manage. And we may, each of us have our days or times that we designate towards antenatal care. But obviously that changes then if a woman goes into labour, or how we fit in the postnatal care around that with regard to the geography and managing visits and that as well too. So it's nothing if not unpredictable, but that's part of the joy of it. But still, you know, all in all, with regard to depending on how many women we may look after in a year, it's only going to be, you know, a few days in the year. Women birth, you know, lots of women birth at 11 in the morning after calling you at 8, and others then birth at 11 at night. So we've no way of knowing. Some take up a lot of time, some don't take up much, and that applies the same for antenatal and postnatal. But that's part of probably its appeal, you know what I mean, as much as it. So obviously the appeal of that continuity of care, meeting women, building that relationship, looking after them through their labour and birth, or supporting our colleagues to do as a second midwife, and then also providing postnatal. So, you know, for some people it might seem a little bit overwhelming, but actually when you make it part of your life and don't worry too much about being on call and just continue on with your day-to-day stuff, you know, it fits in quite well. But that does take, I suppose, a little bit of practice and that as well too. But because of being self-employed and working in that way, you really, you know, you can manage a lot yourself. You can choose to have maybe 3 women who were due to birth quite close together and then have a length of time off. It doesn't always work. Some will go a little bit early, some will go a little bit later. But for the most part, you know, we accept that that's part of what we do. And also it doesn't really, while it does impact a little bit on family, there's things you will miss invariably. The perception that it's a lot worse than it is probably a little incorrect. Because we have total control really over our day-to-day and how busy or quiet we want to be. But that's the joy of the job, and that's why we do it, and that appeals to our personalities maybe a little bit, or how we like to work, or the fact that it's, you know, it allows us to excuse a lot of what we are, maybe our lack of structure in other parts of our life, and that as well too.
That's brilliant, Aisling. Thank you so much. Maris, I'll go on to you next.
Okay. Hi, how are you? As you said, I'm working as an advanced nurse practitioner with the Brothers of Charity Services in Galway, and we provide support services for up to 1,000 individuals in Galway County. Now I work, say, in the west sector of that, so I would carry a caseload of about 65 to 70 individuals, and in that caseload then I operate a traffic light system of red, amber, green. So my primary role is in behaviours that challenge, and you know, I always make the point, even when speaking at a conference, that the vast majority of the people that I support don't engage in behaviours that challenge most of the time. So there's a percentage of that time where, based on elements that may be existing in their life or changes that we have made as a service or something, it may impact on the individuals we're supporting. So I'm constantly making sure that our strategies that we have in place are our, as we say, in terms of a good behaviour support, it's a prescription for quality of life, that we want to make sure that that prescription is given on a daily basis. So it's not that we produce a behaviour support plan and they put it on the shelf and don't carry it out. We want to make sure that constantly people are following the strategies that we have in place. So from that perspective, I'm monitoring those all the time. So the phone could ring at any occasion. Somebody said, look, we have an issue here, or there's something slipping in a particular area. Of late, I suppose, and Karen, I know this because we did that interview for the WIN, that we had great success over the last couple of years in relation to behaviour. So I branched out a bit on requests from the Brothers of Charity to support families at home and individuals in schools. So my role is kind of drifting a bit away, say, from the more residential side of things into supporting families with immediate incidences, and also schools, and trying to make sure that behaviourally individuals get to stay in school and that individuals get to have that home life that families want them to have. So it's changing a bit at the minute, but it's a good change, and gives a little bit of enthusiasm again, you know, so no rest.
Change is definitely good for us. I think it's all why we love our job so much. They all sound like such dynamic roles and busy roles. I suppose going back to something that Aisling said there, what is it like having more autonomy in your role than you used to? Might go in the same order as you spoke before, if that's okay, if you're ready.
Yeah, so having autonomy in the role, I suppose our role would have the first stage of progressing advanced nurse practitioners in advanced practice in the emergency department. We trialled just front loading the services. Initially, just the nurse would, you know, do the bloods, the x-rays and work up the patient, and then the role advanced then to a level where we took on the full episode of care. So the autonomy is fantastic, and we are very much protocol driven. So I would see an array of symptoms, but we're very much protocol driven. So that keeps us safe as practitioners and autonomous practitioners. So we use our code of professional conduct within that, and we use our scope of practice. You know, every nurse is different. We have our protocols, and some nurses might be more confident in different areas, but you know, having our protocols keep us safe and safe autonomous practitioners, and we provide very safe and good quality care as a result of that. So it's really important in advanced practice.
For us as midwives, can you hear me?
Yeah.
Yeah.
Oh yeah. So for us as midwives, we are, I suppose we're autonomous at the point of registration. So that's slightly different maybe. So within our scope of practice in that, our job is to work autonomously from the point of registration, but then our work environment probably limits that a little bit. For myself, I suppose I trained my nursing my midwifery in the UK, I did my nursing in Ireland, and then I worked in New Zealand. So I worked in a very autonomous environment initially, and then I came back to a less autonomous environment in Ireland, which was very influential then in my decision to go into the community and work as a home birth midwife. I had just returned probably New Zealand after 6 months, and then I was out in the community in that as well too. So I enjoyed that. So I wasn't apprehensive about it in that. It was something that I struggled with not having it. So coming back to it. And then obviously, you know, our work is very embedded in best practice and good international evidence and local guidelines. So, you know, we're well within that, we're well able to work within our scope. So, you know, we are, you know, trained, you know, to look after healthy, well women from conception to birth and into the postnatal period. And for those group of women, all things being equal and they wouldn't need to see a doctor at any point at all through their pregnancy, labour and birth. And while that is, and while we still work in an obstetric-led system in the Irish maternity context, there is many women that just that is their maternity experience without us actually having it named as such. So we might think that we actually don't work autonomously in many parts of our jobs in the hospital, but actually in reality we probably do for a certain group of women. So sometimes then, you know, for in the community, it's named probably more so because of the environment rather actually than the work we do. We just have taken it out of the hospital and put it into the community setting. But if we were to look at our day-to-day practice in many areas of the hospital system and for the experience of many women, they would not see a doctor at all, and that would be their experience. They wouldn't consider themselves, maybe they wouldn't reflect on it like that, and we might reflect on it like that. But actually, if we took the time to look at what we do and how we offer care, there is much autonomous practice in midwifery services anyway in this country. So it's to name it and take pride in what we have achieved so far, and then to expand it further for the women that we see in service users.
Okay, I have to admit that I love the autonomy in this particular role because we are very much a multi-D based organisation in terms of, I suppose I'm talking about behaviour all the time. And for a nurse to have this level of autonomy in behaviour is unusual. There are only a few of us who really have that role in intellectual disability services. So I protect it every single day, and I fought long and hard to get that level of autonomy. Behaviour would be seen as kind of a psychology role, looking at the science of behaviour, but I like to see nursing in science role and in terms of that human role that we as nurses bring to the table. So in that instance, then I can act immediately, I suppose, in my autonomous role. I don't need to seek permission from anybody to put practices in place or put strategies in place that are going to have an immediate effect on somebody's life. In particular, I suppose things like if people are engaging in self-injurious behavior, I may have an immediate response to that. That doesn't need to go back to a core group of people because we need an immediate action. So having the autonomy to put things in place is very valuable at that moment in time. It doesn't mean that we don't go back and consult, but it means I have the capacity to act with immediacy. And again, with families as well, going out into that area, being able to act and kind of give advice and give strategies to individual in that immediate moment is vital, because people are actually struggling at that moment in time. They're not going to be able to wait a week or two until we come up with X, Y, or Z. So having that level of autonomy for me is essential, priceless, and something I guard very, very dearly.
And can I just say something as well, Laura, just to like Morris as well, like not every case that we would see in the emergency department is straightforward, and often you get the weird and the wonderful and baffling kind of cases. So with that autonomy, you know, you need expert help, or you need the, you know, you might need to seek to the specialist in orthopedics, or be it in surgery, or whatever the case may be. And we have that autonomy, and we have built on those relations within our hospital, and that's what advanced nurse practitioners do as well. They build on our relations with our multidisciplinary team, and you know, and we're very much respected within our roles because we are the experts in our field. So but it as Morris and Aisling had said, it is great to have it.
That's brilliant. Thank you so much, everyone. That was a wonderful insight kind of into, I suppose, the distance from the newly qualified position to the advanced practice position isn't actually all that far in terms of autonomy, that we have all these tools, these processes, and those really important relationships to give that really high quality care. I suppose expanding on that, I know myself, sometimes I look at the likes of Aisling, who's in such a wonderful position and does such wonderful work as a midwife, and kind of go, oh my God, how do I get there from newly qualified? How do we do that? Just coming out of a 4-year degree, kind of finding our feet. So what are your ideas of best ways to gain experience before going into a role like yours, or how much experience do you think someone needs before approaching this kind of role and development?
So I might start. I started my journey in 2008, and I graduated and was lucky enough to, or maybe unlucky by some, but some people might think, I started working in the emergency department. I remember my day so well, and I was so excited, but petrified at the same time. But I relished the opportunity of becoming an emergency nurse. My advice would be to get time under your belt in the area where you want to be. I was very lucky. I was able to get a placement prior to qualifying. It was an elective placement, so I elected to go back to the emergency department just to be sure that that's where I wanted to be, and I was affirmed after that, and so I got time on my feet. I was very much supported as a staff nurse there, and every day is a school day, and still is. I would still have that approach. You know, the day that I don't learn something new is well, I really need to think about what I'm doing here now. But I would say get time under your belt and find what you like, what gives you joy, what are you passionate about. I knew I was passionate about emergency nursing, and as I said, you know, within the emergency department, they started this trial and rapid assessment, you know, where my role has evolved from. I seen the value of the advancements, and I knew I wanted to get to that level, and there was a lot of work that needed to be done to progress that, and a lot of data was needed. Me personally, myself, I knew I needed a lot of work in terms of having the educational piece, and so I started my education. I done my postgraduate diploma in emergency nursing. And, you know, back when I qualified, I registered as an A&P, you had to have 7 years post-registration. So I had a lot of time to kill before I could be even eligible for an advanced nurse practitioner role. So I continued, and I, you know, I'd done my master's and nurse prescribing, ionizing radiation and so on. And, you know, I really built on my skills. I would be, as well as that, you know, there were a lot of promotional positions going within the emergency department, and I would have been very of the opinion that I didn't want a managerial position. I want to be hands-on. I want to be looking after patients. And a lot of graduates might think like that. And no, I definitely don't want to be. Well, I was one of those. But if you want to be an advanced nurse practitioner, you need to be responsible for yourself, and you need to be able to manage those who are around you, and you need to be able to manage conflict and, you know, multidisciplinary team issues. So I knew that I was going to have to get that experience. So I went for interview and was very successful in that regard. And that in itself was a very different role with great responsibility, but it did give me the experience and the know-how to manage myself and my time and manage staff around me as well, because you do need to have that. And it's all about creating relations as well within all other aspects of nursing within the acute area. And, you know, it was a serious step up in terms of responsibility and delegation and so on, but it was very, very valuable experience for me, looking back now within the role that what I'm in now. You know, as I was doing all my studies, there was no sign of any A&Ps, but I kept the faith that I knew it would happen, and eventually a role did come up, and I interviewed, and I had done many of the courses in the INMO, particularly the interview skills one, which I called on all the experiences that I had to prepare as best I could for that interview. You know, I wanted to be able to put my best foot forward. So, and thankfully I was successful, and I've never looked back. But the advanced nurse practitioner role is very rewarding, and as I said, it is very much direct patient contact, and you're very much an autonomous practitioner, and that to me ticks all the boxes, and I have great satisfaction in my role. But for new graduates, if it is where you want to be, you just need to find the area where you're happy, where you're passionate about, and very proud to be part of. And you know, I encourage anybody to, if they have that passion for advanced practice, to go for it, but be, you know, get that time under your belt after you qualify, you know, because it's great to have that foundation to build on, because when you have a good foundation, everything else will be solid as you do another course and another course and another course. And it might seem quite laborious, but I can tell you it is extremely worthwhile. So that would be just my experiences anyway. So I'll push on to Aisling now, maybe.
Thank you for that. So I suppose I'm a little conflicted when it comes to experience to be a midwife in the community, because I suppose back to that, where I worked in the UK and where I worked in New Zealand, in environments where choosing to birth at home or having midwifery-led care are a mainstream option, then midwives opt in and out of that service from the point of registration. So it's just set up a little bit differently here. So from that point of view, I'm not always, you know, I do sometimes struggle with the midwife who can look after a woman being induced in the labour ward and epidural with syntose and has diabetes, but still needs, 3 to 5 years experience to come into the community to look after a healthy, well woman. But that being said, there's no bad opportunity for learning. Everything is an opportunity for learning. And you know what I mean, the day you're not learning, then really you've lost interest. So it's about, like, if you feel a little bit stagnant, it's about, like, diversifying a little bit, finding a particular niche that might interest you, and just building up all your skills, getting involved in the opportunities to, advance your own practice without being the label of an advanced practitioner, with regard to, autonomous care and clinics and antenatal care, and then skills like suturing and being a puncture cannulation, things like that, getting your skills up in neonatal resuscitation and emergency management, that as well too. And probably the hardest bit can be to actually, it's not your skill, it's to learn not to be afraid, because labour wards can be quite adrenaline fueled, and it's often about drama and what can be high octane, where actually there's a lot of time watching and waiting and observing the process when you work in the community, and learning to see the, not think of it in time and numbers, and think of it in, observation and reading the woman and trusting the process. So sometimes it's less about, it's a little bit of not learning to be afraid, but learning your skills to make you competent when you get the opportunity to come out. And I suppose it is a service, we are, looking at maternity strategy. There is, meant to be an evolution in progress, but it's a bit of a quiet role. So, but hopefully, over time, within all the hospitals, within the service, within your skills to, a bit more autonomy, as I said, within the service anyway, so that you feel that when the opportunities arrive, and it's a growing, the interest in home births has increased over 200%. The numbers of home births has gone up 70%. We're not able to meet the another, but it's not. It's just set up a little differently, that it's up to the midwives themselves to start, as opposed to there being. So get your skills, find your area of passion, maintain your passion, and as I said, all learning is good learning, and even when you learn what not to do as opposed to what to do. Hopefully, things are changing, within the, the Community Midwives Association, within the home birth service, the HSC. It's probably going to look a lot different. We don't really know, but I imagine it's probably going to look a lot different in the next couple of years. And so we'll all be learning on the job and for the job as well in the future.
Okay, I'm going to echo what Karen and Aisling have said. Two of the words they used were passion and that kind of a lack of fear, or feeling that fear and going ahead and doing it anyway, safe in the knowledge that you are somebody that people trust in that role. So building that passion and finding your niche, I think, were two of the things that seemed to come out from both the previous speakers. And that was me. Within the intellectual disability field, there are several different areas where people like to work. I love the area of behaviours that challenge, because I do recognise behind it is somebody struggling to cope. And I do love the individuals. Well, I like, I love too strong a word. I love working with people who are struggling to kind of find their place or their way to get there. And being good at it is something that each of those previous speakers may not have mentioned. We're good at what we do. People look to us in that autonomous role and go, do you know what, you are somebody that's going to make a difference here. And that's a wonderful feeling. And to have achieved that over the period of time that I've been working, and for both previous speakers over their time, to achieve that level of expertise is a wonderful thing. But it also means that when we arrive on a particular scene, we are going to bring that expertise, that experience, that knowledge that makes a massive difference. It's a wonderful feeling to be able to do that, and I'm delighted to be in a particular role where people see me in that way. And I'm very grateful to emergency services and to midwifery, because I've used both over time. Well, my wife has, and they were exceptionally good at what they did.
That's brilliant, Maurice. Thank you. This has been a brilliant discussion. I don't know about anybody else, but I've been seriously and sneakily taking notes. We're going to finish up now and move on, but I want to really thank all of our speakers and ask you just one final question. Just a one-liner, please, in the interest of time. One first thing I wrote down out of that last question was joy. So I would love for you to tell us what is, in one line, what is the joy from your role?
I suppose the joy from my role is being the person that we are, being the expert in our practice. You're delivering this acute care to somebody who's probably having the worst day of their life, but you're the consistent person in their pathway through the emergency department. You're the one that's given them the confident voice, the explanation, the plan of care, and what will happen next. And to be able to instill that confidence and to reassure that person in your care is what gives me joy, without doubt. And that day in, day out, being able to instill that confidence, to instill that reassurance and in me and in the service that they're in, and they're CAM within the emergency department, and they know what the next step is. I love that they know what's next, and they can ask questions, but being able to give that reassurance to the patients is what gives me joy. And they get to the service that they need, be it a surgical service, it may mean an emergency operation. Being able to keep them calm throughout their whole journey is what gives me joy, and they get to where they need to be. That would be me.
For me, I suppose I see myself as a facilitator of a woman's wish for baby. So it is their journey, and my job is to assist them on that journey, so they have the birth they would like to have, and feel safe and heard and protected. And actually, just to to have women say afterwards, thank you, for what you've done for me. That's just really what it's about for me. It's amazing, really. Yeah, I love it.
For me, I suppose it's looking at, because of some of the individuals that we support may not be able to communicate with words. Some of the things I'm then looking for are in terms of behavior, the graph falling away to where a person's quality of life has improved so hugely because we've made a massive difference in terms of the supports we've given them to manage the behaviors and to change their lifestyle, and to watch a graph. I'll give you one example: go from 114 incidences in a year to 1 in 2020, which means there's an equivalent quality of life rise for that individual. It was lovely to sit and listen to his dad say, "This is the happiest my son has ever been." And by such, he said, "This is the happiest that we as a family have ever been." So they're the joy days, and there are many of them, and there are other ones not so joyful, but you thrive on those ones where you've made a massive difference to somebody's life. There's recognition for it, but also within yourself, you've made a massive and a huge difference to the fact that somebody's quality of life has changed. That's what brings me in every day, and that's what keeps me on my guard to make sure that people don't take those supports away that we've put under that person, that we maintain that quality for them, so that in a year's time, we're still hearing, "This is the happiest my son has ever been."
That's brilliant. Thank you all so much. Thank you for giving us your time and sharing about your roles and your experiences and your joy. I know myself as a soon to be qualified midwife, it's just really wonderful to hear.